Good afternoon. This is Dr. John Bennett from Miami of iHealth.tv. Today we have our first show talking about EMRs and national and health IT. Today we have the pleasure of having Niam Yaraghi, a fellow from Brookings Institute. I came across his article, Precision Medicine's First Patient, the National Health IT System. And today he's going to be discussing that along with a group of panelists. So before introducing Niam, why don't we go through the panel and briefly introduce yourself and tell your interest in health IT and EMRs. Good afternoon, Wendy. Why don't we start with you?
Hi. How are you guys doing this? Wherever you may be, I guess not everybody's is in the evening.
This is very informal. You look like you're in your car.
I am. You caught me.
That's dedication.
Moving to and fro places.
Well,
so
okay,
I guess my interest is that I'm a second-year medical student, and I have been able to rotate at several different hospitals with many different medical records. So I've had the joy of learning about 4 or 5 different ones, and even though there's been several different types, they all, of course, have their positives and negatives. But unfortunately, they still don't talk to each other in the sense of different places that is supposed to be connecting to, it just doesn't. And so many of the doctors just say, well, it just doesn't do what it's supposed to, so I'm going to circumvent it. So several hospitals that I've been at, instead of using this technology that they've spent millions of dollars on, simply write it out on paper still and send it to the doctor or send it with the patient and say, here, you deal with it, you figure it out, kind of thing.
Okay, very good, Wendy.
It's very frustrating.
We'll get into the discussion in a little bit. Let's introduce everyone first.
Okay.
Dr. Ben.
Yep, I'm Dr. Venkat Mulpuri. I'm a physician, internal medicine, MD from Saginaw, Michigan. Followed by I did executive MBA from Auckland University. Later, I had some experience with health information technology. I'm so glad to associate with Dr. Bennett because we have the same kind of interest, and I'm really excited to join you guys today.
Welcome, Ben. Simon.
Hello, everyone. My name is Simon Downs. I'm a developmental psychologist in Tokyo, Japan. I'm also a second-year medical student. My experience working with medical records at UCLA, when my mom was in the ICU, I noticed a very convenient medical record system that patients were actually allowed to interact with. And then the next day I was volunteering in the Care Extended program, and we had big, thick paper things that were not interacting at all. It was very confusing. And now I'm rotating in a radiology department, and our radiologist says that she doesn't even bother with the record. She just gets a short one-paragraph sentence from the physician because the interactiveness is just not working.
Okay, Simon, welcome. Dr. Raj?
Hi, guys. This is Dr. Raj, and I've been into this health IT industry since almost 10 years. I'm basically a medical graduate, did my master's in psychology, and right now working with an organization which is more into the HID consulting as well as services provider. Well, my interest is more into the EMRs, EHRs, interoperability, as well as the quality measures, being a medical guide to identify how it's being utilized for benefiting the patient safety or patient's outcome. I've been hearing a couple of things. I would like to discuss more in length about what I know, and I would like to share my experiences because I have the privilege of at least working with different vendors, ranging from physician groups to mid-sized hospitals to larger health systems also. So it was really a pleasure to be with you, John, when all others, so that let's discuss further about it and let's share more about what we know and what can be the changing factors.
Well, welcome, Dr. Raj. Leah, could you introduce yourself, please?
Oh, I can't hear.
Okay. I think you're muted, Leah.
I think, John, you muted her.
Okay, and yeah, it could be that you're right. You're probably right. Okay, we're not professionals here, Liam. No, I'm not losing literature. Anyways, why don't we carry on? Okay, Niam, could you please tell a little bit about yourself and let me know when you're ready to begin going over your article. I'll put it up.
Sure. We can start whenever you want. I mean,
yeah, you want me to put the article up now, or you want to introduce yourself and say what you're doing?
of course. You know, my name is Niam. I'm a fellow here at the Brookings Institution, and my primary area of focus is health information technology. It's great to be on a panel with other real doctors, because I'm a PhD. I'm not a medical doctor, but my PhD was on health information exchange, and that is how I started doing research on information technology in the medical field. I remember from my days at the graduate school, whenever I came up with a wild idea about my research and how health information exchange should be looked at, I discussed it with one of my committee members who happened to be a medical doctor, and then he would kindly point out the flaws that I had in my logic from the perspective of a medical doctor, and then I understood how far I was from reality. And basically that is the reason that I still believe that the real reason for the failure that we are experiencing in the national health IT system is that everybody is involved in designing and building and selling and buying different EHR software, except the real doctors who you are. So as long as guys, like me, are only talking about this, we're going to have the problems that we are having. It's really great to see a group of physicians and medical providers getting together to discuss their point of view about these products, and hopefully, their contribution would result in significant improvements.
Yeah, Niam, we hope to get together and get on the same page, at least start the discussion. So let me share the screen here. Let me make sure you see it okay, of your article. Are you seeing your article there?
Not yet.
Not yet? Okay, let me get your article up there. Brookings Institute. Are you seeing the article yet?
Yeah.
You see it, Liam?
Yes. Yes.
Okay, just guide me along and take us through the article, which is what brought me to meet you.
Well, the article discusses the President Obama's precision medicine initiative. In his 2015 State of the Union address, President Obama announced that they are going to launch a $1 billion project to collect the medical information of 1 million patients in order to transform the way that we practice medicine into a customized medicine. So instead of prescribing one-size-fits-all type of practice, now we're going to have customized medicine in which the medical treatments and plans and procedures are designed based on the individual characteristics of patients. The first step in order to do that project is to get our hands on the complete medical histories of about 1 million unique patients. If we can do so, and if we can be successful with regards to precision medicine initiatives, we are going to experience tremendous outcomes and improvements in terms of how we practice medicine, and also that the patients would benefit a lot because now they can get out of their doctor's offices and hospitals much sooner and receive higher quality of care. There are two challenges from my point of view in precision medicine initiative. The first one is how to get that 1 million patient records. You know, we are now unfortunately living in a situation in which, despite spending about $30 billion of high-tech initiatives on promoting electronic health record systems, we are not experiencing interoperability. The systems cannot talk with each other. And also, it would be really difficult to have a system in which the complete medical histories of a different, you know, unique 1 million patients are in place. The second thing that, you know, the recent Anthem hack and the other health insurers data breaches warns us is the issue of privacy. Even if we could potentially you know, find a solution around interoperability, then how are we going to manage the privacy of those 1 million different patients? So in this article, I warn about the problems that we are having about interoperability. I think the precision medicine is just you know, populist the challenge out there, as long as the challenges with interoperability are not adequately addressed. And the second thing is that even if it addresses the interoperability challenges, we should be able to ensure the privacy of the patients who would be willing to participate in this initiative.
Okay. Okay. Very good. Does anybody have any questions here? Let me get off the screen share first. Okay. Okay. We'll open it up for some questions or comments.
So, Mr. Yaraghi, I'm Dr. Mulpuri from Michigan. I've been involved with HID for quite a while. I'm just wondering, when you mentioned one size fits all, what do you exactly mean? Is it about the vendors having the same kind of data, I mean the format, or is it?
I was referring to the meaningful use incentives and criteria. Let me give you an example.
Okay.
Information technology is supposed to lead to efficiency, and it is just one way to achieve efficiency. If you are managing a large hospital, in order to reduce your readmission rate, maybe hiring more physician assistants and nurses at the emergency departments and, you know, inpatient settings lead to much higher returns on investment. So instead of investing millions of dollars on an EHR system, you may prefer to invest on hiring more physician assistants and nurses in your hospital. So and it completely depends on the technology that you have in your hospital, the patients that you're servicing, the type of insurances that you're working with, and, you know, the current level of staff, and, you know, so many different characteristics that are unique to that specific hospital as a medical service provider. What we are facing now is that you know, HHS is prescribing adoption of expensive electronic health record systems as the best solution to achieve efficiency. So and those criteria of getting reimbursed and meeting the meaningful use stage 1 and 2 criteria are pretty much the same for different healthcare providers, and there's not much variation. So the criteria that you, as a, you know, single physician practice in Michigan, have to attest to are the same criteria that I, as a single physician practice in Washington, D.C., have to attest to. But the fact is that you are dealing with a completely different situation in your area than I am dealing with, and we're both judged based on the same criteria. So that is basically what I meant by one size fits all approach that HHS has is in meaningful use criteria and high-tech incentives.
Okay, thank you.
You're very welcome.
By and large, Niam, are the vendors cooperative with any kind of move towards interoperability, or are they resistant?
Before going ahead, can I put in some of the comments?
Sure.
Yeah, Niam, I'm sorry to let you know that there are a couple of things which I think needs a bit more of understanding on the perspective what you're trying to explain about one size fits all in either precision medicine. I'm not trying to comment on you, but I would like to give more insights into that. He was talking in precision medicine what Obama was planning to do. It's more related towards the kind of medicine being delivered, rather than the kind of not about. It doesn't mean anything about your EHRs, not about the interoperability of that. He was talking more about the kind of medicine being delivered for an average patient. Because right now, if you see, I think my medical fraternities and my friends would definitely agree with me saying that medicine is based on research. And when you do research, you understand what is the average of it. And when you do statistically analyze the results, then you come to a conclusion that this is a good thing or this is not a good thing. So what's happening right now is about how the medicine is being delivered based on the facts that we know about a larger group of research. But what Obama wants to get along is more towards it's not one size that fits all. He doesn't want to give the same treatment for all. It's about the treatment being rendered to different people based on their different symptomatology or different conditions, or might be variations of the person. That's the reason why he's talking about the genealogy, or you talk about the genetics over there.
Yeah, when I was talking about one size fits all, I was not commenting on precision medicine. I was commenting on the incentives for meaningful use of EHRs. Of course, precision medicine, as its name, refers to, is precision. So precisely everyone is different from everybody else. But the link between the precision medicine initiative as a completely medical science type of an initiative and electronic health records as a medical systems initiative is the fact that in order to be able to do research in precision medicine initiative, you should be able to have access to the medical records of the patients. For example, you need to have their lab tests, you need to have their radiology examinations, you need to have their doctor's notes and everything. And in order to be able to get that, you should solve the interoperability problem. So that is a link. I mean, I don't want to comment on precision medicine because honestly, it's your area.
Even coming to that
my area, but
coming to that, as you said,
to be able to start with that, you have to be able to get the data.
That's
and to get the data, you cannot have a system which is not interoperable.
That's true. To give a bit of inputs on what you're trying to analyze this particular condition of EMRs right now. I don't know how many of you are completely from the starting of the EMR scenario or starting of Obama plan till now. I've been in the industry starting from meaningful use stage 1 till now. I'm still continuing that way. Like I could definitely see there are definitely a lot of still outs, a lot of hurdles, but at the same time it's moving in a proper direction. I mean, owing to the challenge of the physician, that's again completely related to the functional aspect of EHR. See, it's an industry where you're trying to talk about trying to satisfy different spectrums of specialties. It's not an easy task. As a nephrologist, you need something else in your record. As a neurologist, you need something else in your record. As a pediatrician, you need something else in your record. So as a vendor cannot target the whole thing with a single motive. As simple as it is. You want to customize.
Right.
The more it's getting customized, the harder it's becoming for interoperability. But at the same time, trying to bring all that stuff into the pattern, you have all the standards being laid, like HSPs, or you talk about the HIE plannings like NHIN, or you talk about the regional extension centers coming into picture and trying to help you out in this particular protocol. Now, as you said, when you see the challenge of either going ahead with an EMR or trying to be putting more towards with a physician assistant or a nurse practitioner. I'm basically in New Jersey. So you know that how, say when you have a lot of physicians going ahead and you have a lot of nurse practitioners coming in, the kind of environment what you're trying to work it out is not changing up. Like when you're trying to enhance the systems from what you have, from the level of just mere system which is helpful for data to a system which can help you in deciding what to do, what not to do. That's how it's being done in your oncology. See, in oncology, if you can go precisely about it, 90% or 99% of the doctors will rely on data analyzed by the system to deliver the treatment, especially how much of precision you need to go with. Either you're talking about the dosage of your radiology drugs, or you're talking about the site, the depth of the site, everything. So I mean to say that technology is going towards the direction which it has to go. The only change, as you said, is trying to overcome the hurdles of interoperability. Or as you said, you are trying to talk about, I just have gone through your article over there where you said the major challenge is the privacy. Yes, definitely, privacy is one of the challenge for anything. Irrespective of EMRs, I do, because I've been dealing with EMRs for almost 6 to 7 years continuously. I could definitely say I've been working with different kinds of EMRs. As where you could see, they are all trying to tackle a couple of things, but privacy, specifically for healthcare, is a bit different component when compared to non-health. When you have a protected health information to be done, the protocols you want to follow, they are a bit more stronger, at the same time more newer to USA. You're already talking about. If you see the global scenario, Netherlands has wonderful integrated systems. If you see UK, you have NHS, which is operating better. It's one system which is operating across. Now, in US, you are trying to bring in all that stuff, bringing together and trying to enhance this particular thing. It definitely takes time, as you say. And at the same time, there are things which are beyond. I think it's not something like only a legislation can do. The adoption, when you said, I could say that clinicians are not being involved into the systems implementations or integration or development. Let us put precisely on the development component.
Okay.
Now,
Do you want to give Niam a chance to comment?
hello?
Do you want to comment on what Dr. Raj said, Niam?
Yeah, I mean, I'm not sure if the industry is going as planned. You know, the meaningful use criteria, regardless of their quality, are a good basis of measurement for us if we want to see if we have reached the goals that we had or not. And just look at the level of attestation to meaningful use stage 2. Although they've been, I think, set a low bar, there are so many different hospitals and medical providers who have not been able to reach those goals. So this is with regards to meaningful stage 2. For if you read the proposed meaningful stage 3 criteria, and the reactions to that, the ones that I've been exposed to are generally negative. So you know they've not been able to come up with even some criteria that everybody could agree on. The only thing that we have been successful is adoption. Now we have about almost every medical provider is about 97%, 95%, something around that area, of hospitals and physicians having adopted some electronic health record system as a result of spending $28 billion on high-tech incentives. And that's it. You know, we have not been, the executive order of President Bush in 2004 which led to building ONC, and then high-tech in 2009, that the mission of ONC was to enable every American to have access to their records everywhere in the United States within 10 years. Now, it's 2015, we're 11 years from there. And I would say not a single American can have access to all of their medical records anywhere in the United States.
Right, right, right.
The only person that can think of maybe is President Obama, because he's president, and the Secret Service and everybody gets his medical records, for his security. But I can bet that none of you have access to all of your medical records.
Right.
Not even your recent medical records. So I think measuring our performance with regards to meaningful use stage criteria, and also the very first mission of building ONC, we are very far from what we wanted to be. Then I would like to add something else. There was a study came out from some economists at Northwestern University. I can find the paper and send it for you, which was basically analyzing the effects of high-tech incentives. And what they were concluding was the fact that if we had not to spend a penny on promoting EHRs, we would have experienced the same level of EHR adoption, only with a 2-year lag. So if in 2015 we are experiencing 97% adoption, we would have experienced the same rate of adoption in 2017. So what we achieved with those kind of investments is just 2 years. We bought ourselves 2 years of time, and that's it. And in terms of interoperability, I think everybody on the panel already knows, where we are right now. We don't have any interoperable systems. And to get back to you, John, with the reactions of EHR vendors about becoming interoperable. Again, we have 2 types of EHR vendors: Epic and others.
Right.
Epic has 50% of the market, and then there are a host of different EHRs that together have the rest of the market. What is happening now is that Epic is relying on its huge network of patients and does not have any need to join the others in order to solve the interoperability problem, because if Epic allows other people to connect to its systems and use their medical information, they're somehow losing their edge over the market. Their competitive advantage right now is that they can provide easier access to the records of the other physicians who already have Epic systems. Now, and that is the reason that you see larger hospitals who have already adopted Epic systems are pushing the smaller practices to go and also adopt Epic system, because if you have an Epic system and I have an Epic system, then it's easier for us to exchange information. But if now Epic allows other EHR systems like Athena to also become interoperable with their own systems, then if a large hospital has Epic system, then they don't have any reason to push me as a single provider to go and also adopt Epic. Then now that they are interoperable, I can go and adopt any other software that I wish. So Epic would potentially lose one customer.
So there's no economic stimulus for Epic to change.
Absolutely, yeah. I mean, they should be crazy to do that. If I was the CEO of Epic, I would not become interoperable.
Right, right.
If you were the CEO of Epic, you would not become interoperable.
Yeah. I'm just beholden to the stockholders. That's all. I'm not beholden to improve patient care. My goal is to make money for my company.
Absolutely.
Capitalism. Any of you guys have something to say, Wendy? You're kind of quiet there in the car.
Yeah, I have a lot to say about what everyone has said. I guess when I think of interoperative, I also think of, I have two main things that I think of. One is those that have Epic and those willing to work with each other or any other electronic medical system. But Epic is definitely kind of the one that you talk about when you talk about a standard, I guess. So the whole hospital has Epic. Now, how do you get the doctors to talk to each other, first of all? And then what seems to be Niam's more, what he was talking about is, now that you have a doctor with one system, how do they then communicate with a doctor with another system? And as he pointed out, as a competing company, no one's going to want to talk to each other unless there's a government mandate saying you must talk to each other. You must create a system in which that they can talk to each other, whether it be a software thing or some sort of download of information, something along those lines.
Well,
of course, when you start doing that, then you start talking about HIPAA. So if I download all of my patient's information to a different doctor, well, if that doctor is not seeing all of my patients, then I've just violated HIPAA if I don't make my entire population sign something saying that this doctor who has no care can have access to my records. So that's kind of, I mean, you're working on that. The problem with meaningful use is that a lot of meaningful use criteria doesn't necessarily do what you're hoping it to do. For example, one of the big things is to get communication through email. So for example, on Epic, I saw the patient, so they've come in, and in the evening when they're gone, then per meaningful use, in order to get my meaningful use numbers, I would have to sit down every night, every evening, after I've had however many hours in the clinic, and type an email to each one of my patients, and they have to email back. And then that is how I get my one criteria of meaningful use. So you have a sick person who has come in, feels awful, they're curled up in bed, and now you want them to get online to send you an email, and they have no incentive. What is their incentive? They have no incentive. This is just like in education trying to get students to test well. I'm giving them a standardized test that the entire day I'm bored out of my mind. I don't get to eat with my friends. I don't get to speak during the day. I have no communication with any of my friends, and you want me to do well on this test? This is the same thing. This is the same problem that you see in education. I'm being tested on whether my patient feels like sending me an email. Now, granted, this is just one of the meaningful use criteria, and not to mention, as I've been in different places, if I'm in a more poverty-stricken area where most patients don't have a computer in the house, now they have to go someplace else to a public system to send me an email for me to get credit. This particular flaw in getting communication back and forth doesn't prove to me that I'm enhancing my medical use or my meaningful use, in the sense that I am taking better care of my patient by sending them an email after each workday. That's my problem. And there's several other criterias that I I understand where they're coming from. They want you to use they want you to use it. They want you to be able to talk from doctor to doctor. But so many of our patients, if I have a patient and I want them to see my patient, I want to give them a call. And not only that, I want the other doctor to give me a call. Why? Because when I look at text message, which is basically what this is, I don't have time to say everything. I don't have time to print out everything. I don't have time to say everything that I want to say. Or I don't want a record of it. I'm sending you this patient because I think they're full of it. I'm not going to send that over Epic. It's very frustrating on the other side of trying to fulfill the meaningful use. So in that sense, what can we do to prove that we're using the services that are there? Because we kind of haven't really brought up, there are some amazing things that electronic medical system has brought to medicine. Completely amazing, wonderful things. But getting people to use that is completely a different thing. You said, well, we have these high-tech incentives, and they didn't really do anything. I don't know. I think that changing the culture from paper to electronic, you've done something, even if you weren't able to quantify it, even if you weren't able to give it a number.
Okay, Niam, do you want to comment?
Yeah. I really appreciate your comments, and I love the example that you gave me, that there are some doctors who are working in urban areas who are serving patients who have access to email on their mobile phones, and there's some other doctors who are serving another population of less privileged patients who do not have access to their emails. And then, how are you going to compare these two different types of doctors based on the same criteria? I also agree with you that changing the culture and shifting it towards electronic health records is a good thing. Obviously, I do agree with you. But the way that I see it, the summary of all of my thoughts is in a recent paper that I published for Brookings. It's called A Sustainable Business Model for Health Information Exchange, the Solution to National Health IT Interoperability Problem. And in that paper, what I argue is that there are so many different business disincentives and economic disincentives that act as barriers to information exchange and interoperability in the medical system. And in order to solve the interoperability problem, we should eliminate the role of government and should align the economic incentives of different players in the market, from ACOs, hospitals, single physician practices, labs, radiology centers, and EHR vendors, in order to have some economic reason in order to actively use their systems and engage in information exchange. I would like to kindly ask you to go and take a look at that report. So that is the only comment that I have on this. I mean, I share your frustration on the meaningful use stages and how difficult it is, and how sometimes honestly meaningless they are in order to attest to them. And I believe that one of the possible ways to solve this is to promote innovative entrepreneurship in the medical community, in order to let the people decide on their own that what is best for them and get what they need to get.
Mm-hmm. Ben, do you have anything to say, Dr. Ben?
Yeah, I'm just wondering, I mean, let's get back to the core problem. I mean, I thought today's topic is basically interoperability, right? So, I mean, could you,
Well, it's a pretty broad topic, actually, Niam.
I know, but
Yeah.
we haven't discussed the basic problems. I mean,
Okay, okay.
so since Dr. Donald brought this topic on the LinkedIn, let's discuss about it a little bit.
Okay.
What are the components of this interoperability, and why is it? I mean, I know security is one of the major problems, like the privacy and security breaching. Other than that, I mean, what are the other components of this health information exchange that are kind of slowing down the process? I mean, without getting there as we had expected, because we have gotten EMR to this far to me. I mean, like Wendy pointed out, this is an amazing thing that we are able to use it, at least the majority of the physicians. But from here, how to get to the next stage, like, how to get the information from different areas, how to aggregate, and then how to exchange this information for different uses. So what are the major blocks and what are the major players here? So could you highlight on this?
Yeah,
Mr. Neal?
okay, let me give you an example. The reason that we have EMRs, and they are good things, is that there was a reason for vendors, for IT vendors such as Epic and others, to get into this field and produce such products, because there was a source of revenue, $35 billion was set aside for these things. Okay, so that money led to such a situation that we have now. Everybody has EMRs and EHRs. There is no reason to exchange information. So suppose that you have a radiology center, and in the current fee-for-service payment model that Medicare and Medicaid everybody has, you are getting paid for the number of radiology examinations that you perform on the patients. So a patient is potentially a customer for you. Would you like to have 2 customers or 1 customer? You would like to have 2. So if you actively engage in health information exchange and create a copy of that radiology examination and push it to every medical provider, to every primary care physician and specialist in your area, so that they can have access to the radiology exam that you created last month, and thus they are not required to reorder another radiology examination, you're basically losing your own market.
Okay.
Okay.
So from the perspective of a owner of or an investor in a radiology center, the worst thing that they can happen to them is that the number of radiology orders from doctors are reducing. That would be the nightmare. That is the thing that keeps the investors of that radiology center awake at night. So you don't want to see the number of customers reducing, just like any other business. If you go ahead and make your results interoperable, if you let everybody have access to that, you're effectively doing the same thing that you don't want to happen. So that is one reason for the fact that we are not seeing interoperability among medical data providers such as radiologies and labs and hospitals with the others. Let me give you another example. Again, there was another very recent study published in the American Journal of Health Economics that was analyzing the state-level regulations on patients' rights to have access to their full medical histories. And they were showing that in the states where it is much easier for the patients to have access to their records and get an electronic copy of that, it is much more likely to see doctor shopping. So if I, as a patient, can get my hands on my records, then it's much more likely that I go and seek a second opinion. it's much more likely for me to go ahead and change my primary care provider and go with another doctor. So, you know, again, being interoperable sometimes is even against the economic incentives of medical providers. They don't want to have their patients, you know, going to the practices of other doctors. So medical data providers, such as, you know, as I said, labs and radiology centers have a disincentive to share their data. Doctors have a disincentive to share their data, or at least they don't have as that big of an incentive to do it. And then, unfortunately, another thing that is happening is that the patients are not aware of the value of their medical records. We did a survey on a nationally representative sample of the U.S. population, and just asked them a simple question. I asked them, how much are you willing to pay in order to have your medical records delivered to you electronically in a very secure format, so you don't have the privacy and security concern? 80% of the population said they are not willing to pay a penny for that. It means that 80% of the population are unaware of the value of those records for themselves.
Right.
So the patients don't know it, don't know the value, and they are not bothering their doctors about interoperability. The doctors at least do not have any incentive to become interoperable, most of them, from economic perspective. Of course, I know, you know, every doctor takes an oath to do the best that they can in order to provide the best care to their patients, but, you know, let's be honest, economics are also in play when we're talking about medicine. And the third thing is that medical data providers, you know, clearly have a disincentive to do it. So what I am arguing is that even if it was technically possible, even if it was quite easy that we could exchange information if we wanted to, we wouldn't see as that much of an information exchange and interoperability going on. So interoperability is not a technical problem. It's not Epic's fault. It's not other EHR's fault.
But the bottom line is we are putting 1,000 patients on death. I mean, you know, this is what Donald pointed out, like, you know, since this is not, the information is not exchanged properly, it's putting 1,000 patients at risk for death.
Yeah, of course. Unfortunately, yes.
Yeah,
Yes.
you know, I don't know if Niam knows about Donald's organization. Basically, Niam, it's an anesthesiologist from Ohio that's starting a petition, a grassroots petition.
Yeah, I read that petition. Yeah, on change.org. Yeah.
Okay, you know about it. Okay.
Yeah.
Well, essentially, what you're saying is, maybe you didn't say it, but you're kind of hinting at the government needs to step in and say, okay, private vendors and hospitals, you have to make it interoperable.
And the government already did. So in this SGR repeal bill that, you know, fortunately passed the Congress, passed the House, and is now waiting for the Senate vote, in the SGR bill, there are a lot of areas that are focusing on interoperability. So one of the best things that they are talking about is now that interoperability, the HHS has the right to go and investigate if there is any medical provider or EHR vendor that is willfully interrupting interoperability. Right. And if they are found guilty, then there can be penalties.
Okay.
So basically, the Congress is saying that you have to become interoperable.
Oh, okay.
So
that was going to be my question. Are there any laws with teeth in the works that forces vendors to become interoperable? I was going to ask that.
So that is one of them, and then the other part of this SGR bill talks about decertification. Now, all of these EHR softwares that you are using and getting reimbursed from the high-tech incentives have to be certified. And in this bill, it says that the electronic health record vendors should either provide APIs that facilitate the exchange of information between these systems, and in other words, makes them interoperable, or they would be decertified, which means that they can't make any more money. So that is also being put in the bill, and I honestly think that it would pass the Senate as well. However, I'm not sure if it's possible to implement that law. I mean, again, unfortunately, we have a system that have 50% of the market share, and I published another post talking about this SGR bill, and then another bill with Representative Burgess from Texas in Congress talking about interoperability, and then they're saying that, oh, if Epic does not provide interoperability, we are going and decertify them. Well, the reality is that Epic has 50% of the total U.S. population in their system. Can you decertify them? I mean, they are too big to fail. You cannot decertify them.
Right.
You have to find another way in order to persuade Epic to come to the table and act as a mature person and enable interoperability. So honestly, I think that the problem has become much more complicated than we expect. I think Congress is doing whatever it can do. It has put in place incentives for interoperability in this exchange. All of these meaningful use stage 3 are now focused on information exchange. So there are at least short-term incentives for providers to engage in health information exchange and become interoperable. Then there are penalties for EHR vendors if they do not become interoperable. However, this is from a regulatory standpoint. I am not really sure how successful HHS would be in implementing those rules. So they would if it passes the Congress, the new SGR bill would be in effect from 2018. So January 2018. At least those parts related to health IT and interoperability. I mean, we can't say anything. You just have to wait until 2018 and see how it changes the field.
Yeah, that leads me to the really big question I have, Niam, which is really why I have you here. Mm-hmm. Let me just propose this scenario. Suppose this grassroots movement with Donald about getting 25,000 doctors and healthcare professionals to sign a petition and say, hey, make it interoperable, have the government make vendors and hospitals have an interoperative system. Will the government come back and say, whoa, wait a minute, we've already are working on that?
Yeah, that was, except the thing that I want to tell you.
Yeah.
I read that petition, and I completely agree with that. And I want to tell you that the Congress would ask you, what else do you want me to do?
Right, right. Well,
I think they have done whatever they could.
Okay.
In terms of regulation, in order to solve the interoperability problem.
Are you happy with this, the way the Congress has that law structured? Do you think it's strong? You think it'll work?
Honestly, I don't know.
Oh, okay.
Because, in theory it should work, but as I said, one of the parts is decertification. Right. I'm not sure if Congress can go and decertify these large EHR vendors. They're too big now.
Right, right.
So
very big lobbyists.
Exactly. So I'm not sure if the Congress can do that. But there is something that I believe in, and as it was mentioned earlier, if there is only one thing that high tech has achieved, is this cultural shift, is the fact that you and I are now talking to each other about something called interoperability. So we have invested enough in EHRs and EMRs and data entry, and the culture has shifted enough that now we see electronic interoperability as a big problem. And now we also have access to silos of electronic medical information all around the country in every physician's computer. What would happen is that what I predict is that any change that any meaningful change that we would observe would come through private businesses and not through Congress. There has been $5 billion in private equity investments on health IT from private business. $5 billion. You know, on average, it's more than the annual high-tech spending on IT, and it's a huge thing. I believe that we can only innovate our way out of this problem. We cannot regulate our way out of this problem.
Okay. Oh, that's an important point.
I really believe in the innovative spirit of the American nation, and I believe that they would be able to solve it. Now that everything is in electronic format, and now that everybody is focusing on health IT and how to become more innovative, and more importantly, now that we are changing the payment systems from fee-for-service to a fee-for-value, and now that the medical providers and the other players in the market are seeing a reason to become more efficient through interoperability, I believe that we can solve this problem sooner than we believe.
Very good, Niam. We don't want to take you too long. Let me just ask the people if they have one more question. Does anybody have a question?
I have a quick one.
I know Simon does in Japan.
Hi. Thank you, Niam. A very, very interesting topic. I would just like to ask, in reaching an acceptable level of interoperability, is there a successful model that you can follow, perhaps one in another country, that has been working very well? That's my first question. And secondly, are there any negative drawback? Are there anything negative? Is there anything negative about coming to a perfectly balanced system? Is there anything that might not be good about it?
Thank you for the question. The other successful examples may be the systems in Sweden, England, and Singapore. But the biggest difference between those systems and the United States is that most of them are the single payer. So the government is the only payer of healthcare, and they can dictate what to do. So their success stories may not necessarily, be feasible to be implemented here in the United States. Then the drawbacks from interoperability, I think, it's just like any other IT systems. You're giving up some part of your privacy as a patient. As a doctor, again, you're giving up some part of your privacy. I think that physicians are entitled to some level of privacy in how they make medical decisions. How they treat their patients, and with complete interoperability, that would be somehow given away for the sake of higher quality of the patients and better overall medical system. But in comparison, comparing the risks of interoperability with its benefits, I would say the benefits clearly outweigh the risks that we have.
Thank you.
You're very welcome.
One quick comment, Niam. The VA system, don't they have a pretty interoperative EMR? And I'm new to this.
Works well. The VA system works very well within VA.
Oh, okay.
The problem that they have is that when a soldier is an army, his health care is provided by Department of Defense, DoD.
Right.
And then when that soldier retires, and now from a single point of time onward, it's been covered by VA, then the doctors at the VA do not have access to the medical record of that soldier in the DoD. So all of these talks about this new EMR system of VA and DoD is to connect these two with each other.
Okay, very good. Any last questions, Dr. Raj or Dr. Ben?
Yeah,
Or
just
comments? Okay, go ahead.
Raj, do you have any question?
You go ahead, go ahead.
Yeah, I'm just wondering, is there any other country leading in this aspect? Like, I mean, as we're talking about this HIE, is there any country that's leading or ahead of US?
I think Simon just asked that question.
No,
Wake up, wake up.
no, but he didn't point out a specific answer for this. I know there are problems with this, but you know,
Yeah.
which country is leading
Yeah.
in this aspect?
Netherlands has ability across the whole country. Netherlands is one of the other country.
Okay, that's good.
But at the same time, as you said, most of the other countries which cannot be taken as a core example because, as I said, it's a uni or one payer towards the hospital system, or the hospital system is not as big as US ones, or the multiple systems are not available in the other countries like you talk about UK. It's only the NHS, which is covering the whole thing. So the whole maintenance of the system is not that challenging. I definitely agree with your points. What you said is right, that I do believe that it's not the regulation that can take it further from here. It's more about the inspiration from what we have achieved till now. From there, the innovation of how we can just do it better can take it further. As you said, as many regulatory points as you want to put in, might not really make the patient really feel the value of it until they feel the value of it by seeing it. Like definitely there are a lot of cases where you can take it by example, where they feel the value of having an exchange immediately done. If a patient goes to a doctor suddenly and he sees that suddenly something happens for his son, and he goes there, he doesn't know what happened, why it happened, and all, and then he want to go to a doctor and say, what happened? I don't know. He fell down or something like choking, and then you don't know what is the previous history, whether he had atrial fibrillations or might be syncope or might be X, Y, Z. So these kind of things, the value addition, what you can bring in, can get more and more beneficiary once they get adopted, as I said, increasing the adoption. And I do agree with epic versus non-epic. Definitely that's there, epic versus non-epic. But I don't believe that that is going to be a really major factor for anybody to really take it away from getting further ahead. Because everybody has their own incentive in getting exchange done. So if you really see that, for example, now we are seeing Hangouts. Gmail started with only email exchange. Now we are having Hangouts. So it's all again like how you perceive, how much you utilize. I do believe that the more it is utilized, the better it gives the outcomes. I do agree with most of your points, like saying that it's about the innovation and adoption rather than the regulatory point to really push it further.
Very good.
Thank
Okay, I think we'll wrap it up now. Thank you, all you gentlemen, and especially Niam, for coming out and spending the time.
Thank you very
The
much.
dialogue is just beginning, Niam.
Thanks for having me, and please keep me posted and updated about your efforts.
Yes, hang on. I'm just going to stop the broadcast. Good day, world.